everyone. In this video, I will be covering cholelithiasis. So, what is cholelithiasis? Cholelithiasis is defined as stones in gallbladder. Okay, now these stones may be cholesterol stones or pigment stones. Cholelithiasis generally presents with, maybe asymptomatic sometimes, or may present with biliary colic. So, what is biliary colic? Biliary colic is right upper quadrant abdominal pain following meals. And usually the meals here are very fatty or heavy meals. Okay, so these right upper quadrant pain is accompanied with nausea and vomiting that self-resolves. Okay, now what causes this colicky pain is the release of cholecystokinin. All right, so this release of cholecystokinin, this CCK causes contraction of the gallbladder. Okay, so the CCK is released from the pancreas. Okay, and this in turn causes contraction of the gallbladder, and that if there is a stone in the gallbladder, this causes dislodges in the cystic duct and may result in pain. Okay, so that is biliary colic. Now again, as we said that these stones are very commonly seen in ladies. Why? Because females, tend to get a lot of cholesterol stones due to pregnancy, hormonal changes, all right, and mostly more than 40 years of age, and because of obesity, fat. Okay, now other reason is impaired gallbladder emptying. Now this impaired gallbladder emptying may be because of a TPN, all right, because what happens here is when you put up the patient on TPN, total parenteral nutrition, the gallbladder is not functioning. You're basically impairing the movement of the gallbladder. There's no release of CCK, so there's no contraction of the gallbladder. So it's basically remain stable. Okay, so that can result in building up stones. Starvation, again the same reason. Diabetes, all right. Then biliary stasis, secondary to rapid weight loss, all right. And remember that these stones, cholesterol stones, are very commonly seen in Native American heritage. Okay, so those are cholesterol stones. How about the pigment stones? Pigment stones are commonly seen in cirrhosis, biliary stasis, and chronic hemolysis. All right, a very common classic question is hereditary spherocytosis. Patients present with cholelithiasis. So remember that those patients chronically undergo hemolysis and can present with gallstones. So pathophysiology is cholesterol saturation can cause impaired gallbladder motility. Okay, and basically gallstones can lead to mechanical obstruction of the biliary tract and cause bacterial overgrowth. So patients can have a stone with infection, and therefore it is associated with acute cholecystitis, ascending cholangitis, acute pancreatitis, and gallstone ileus. So how does patient present? As I said, patients with cholelithiasis may be asymptomatic, but sometimes patient can be symptomatic, presents with biliary colic. These are colicky pain in the right upper quadrant pain that may radiate to the shoulder, especially the right shoulder, triggered by fatty or heavy food. Episodes may be self-resolving. All right. What is the diagnostics tests? Now, you suspect a patient with cholelithiasis. Okay. So first thing, always you do is an ultrasound. Hocus pocus, all right, abdominal ultrasound. You do abdominal ultrasound, you look for gallstones, okay? So right upper quadrant ultrasound, look for gallstones. Then MRCP when the results are equivocal, okay? ERCP is both diagnostic and therapeutic. You do it if intervention is indicated, okay? Studies will show alkaline phosphatase and bilirubin may be elevated, but only mildly. Amylase to assess for gallstone pancreatitis, and the diagnostic criteria is gallstones on imaging. Okay, so that is how you diagnose. Now, differentials are very important. The differentials are peptic ulcer disease and sphincter of Oddi dysfunction. Peptic ulcer disease, how would you differentiate from cholelithiasis? That this pain is epigastric, drowning pain that may improve with meals. An ultrasound will show no stones. Okay? Sphincter of Oddi dysfunction, this presents similar to biliary colic. It is diagnosed with manometry and treated with sphincterectomy via ERCP. Now let's understand in more detail about sphincter of Oddi. Okay? With the help of a question. So here is a question related to sphincter of Oddi dysfunction. So it's a 35-year-old woman who presents to the emergency department with right upper quadrant pain. She reports that the pain is not new and usually starts within half an hour of eating a meal. The pain has been previously diagnosed as biliary colic, and she underwent a cholecystectomy 3 months ago for symptomatic biliary colic. Okay, now right upper quadrant, she comes back, okay, to the hospital. She complains of right upper quadrant pain that reveals a surgical, so it was evaluated. So ultrasound reveals a surgically absent gallbladder and a dilated common bile duct without evidence of stones. Okay, so there's no stone in the gallbladder, the cystic duct, and there's no gallbladder. Now, MRCP is done, shows no evidence of biliary compression or obstruction. ERCP shows no evidence of biliary stones or sludge. Lab results are as follows, which is nearly normal. Which of the following is the definitive treatment for this patient's condition? So this gives you a tip-off, okay? This is basically sphincter of Oddi dysfunction, okay? And a very common cause, post-cholecystectomy. Okay, so what you do is sphincterectomy. Okay, so the gold standard for diagnosis of sphincter of Oddi dysfunction is manometry, and treatment usually involves sphincterectomy. Okay, so how do you know that this patient has sphincter of Oddi dysfunction? So this patient presents with pain resembling biliary colic that has persisted despite cholecystectomy, which suggests a diagnosis of sphincter of Oddi dysfunction. Remember that we have excluded all other causes. We have done MRCP, we have done ERCP, and everything was excluded. Possibly, cholelithiasis, we have excluded all that. So the next thing that should come in your mind is sphincter of Oddi dysfunction, where patients present with persistent pain despite cholecystectomy. Okay, and it resembles biliary colic, right? So sphincter of Oddi dysfunction is treated with sphincterectomy, and the sphincter of Oddi regulates flow of pancreatic juice and bile into the second part of the duodenum. So here we have a picture here where this is the sphincter of Oddi. So it's the collection of the bile along with pancreatic juices drains into the second part of the duodenum. Okay. So SOD is thought to involve both stenosis and dyskinesia of the sphincter. This is very important. It causes both stenosis or it can cause dyskinesia. This results in backup of bile into the biliary tree, causes dilation of the common bile duct and elevation of ALT, AST, ALP, and total bilirubin. Amylase and lipase can either be normal or mildly elevated. So if you look here, if there is any dysfunction of the sphincter of Oddi, let's say that it is stenosed. So all the juices, that is the liver enzymes, everything, it results in backup. All right, so the common bile duct may dilate. In fact, this can result in pancreatitis. The sphincter of Oddi dysfunction can result in pancreatitis. Okay, so then sphincter of Oddi dysfunction is also most common following an inflammatory process in the abdomen, including surgery, gastric bypass, cholecystectomy, or pancreatitis. Okay, so this can happen anytime following surgery or pancreatitis. Okay, now her main pain was likely worse following her surgery because analgesic like morphine can exacerbate sphincter of body dysfunction. This is very high yield. Lastly, the finding of a dilated common bile duct without evidence of stone is a very common finding of sphincter of body dysfunction and is a buzzword for the condition. Okay, so what's the buzzword for SOD? Is the dilation of the common bile duct without stone post cholecystectomy. Okay, very important. So this is all about sphincter of OD dysfunction. Okay. Then how do you treat? This is the main area. So yes, patients sometimes present with incidental asymptomatic gallstones who do not require any treatment. Or sometimes antibiotics are needed for simple cholelithiasis and biliary colic. Okay, so always the first line is addressing the pain. So you treat the pain with analgesics like NSAIDs, and diet is very important. You avoid fatty food that trigger biliary colic and rehydrate the patient. Then elective cholecystectomy, that is indicated in symptomatic cholelithiasis. Um, so within 72 hours of admission, you do an elective cholecystectomy. Now this part is very important. Now elective cholecystectomy is also indicated in patients with who are Native American heritage because these patients, these heritage, they have increased incidence of cholesterol gallstones. Okay, so very common Native American heritage, Procillian gallbladder, gallstone pancreatitis. Now these three conditions, okay, these patients are at risk for cholangiocarcinoma and therefore elective cholecystectomy is indicated. Again, Native American heritage, Procillian gallbladder, and gallstone pancreatitis. These patients, because they have a risk of cholangiocarcinoma, then you do an elective cholecystectomy. Great. Then the second line treatment is ursodeoxycholic acid, where patients who are unwilling or have any contraindication to cholecystectomy can be used as a prophylaxis because ursodeoxycholic acid can be used in such patients. Okay, complication of cholecystitis, cholelithiasis, secondary infections. Okay, and secondary infections again may be EEK, just E. coli, enterococci, Enterobacter, and Klebsiella. All right, thank you so much. Please do subscribe my channel and hit the like button. See you in the next video. Thank you.